Welcome, Texoma, to this interactive Facebook Live with United Regional Healthcare System. I'm Ashley Fitzwater with News Channel 6. Joining me this evening is Dr. Wagler. Now, you are a rheumatologist. First of all, we just want to say welcome tonight, and we want people watching to know that they need to log on and ask those questions,
Absolutely.
Tag their friends, and just ask away, because that's what you're here for tonight, correct?
Absolutely. Very happy to be here.
Well, he is a rheumatologist with United Regional Physicians Group, and as people are joining us, I want to take a little time to get to know more about Dr. Wagler, and if you could just tell us how long you've been at United Regional in this area, and I know you got some kiddos, so just tell us a little bit about you.
Absolutely. So I've been here for almost 5 years now, and I came to Wichita Falls with my family after finishing my time in the Army. We were stationed in El Paso, Texas, and we were this was our first stop after finishing up there. And so have 4 children, 2 sons and 2 daughters, and so they range in age from 5 to 13. So it's never a dull moment at home.
I bet.
And
a teenager, we all know how to pray for the parents, right?
Absolutely.
I have a teenager too. 2 of them.
Absolutely.
You love them, though.
We do. So, yeah, so I've been here now for almost 5 years, and it's been great.
Well, we are excited today to talk about all it is that you have to offer the community, and hopefully just start answering some questions about what it is that rheumatologists do, what it is, why they would come see you. And but before we get into that, I love this connection. You mentioned that y'all were in El Paso, but Dr. Wagler actually joined United Regional in 2018 after serving his country in the U.S. Army, where he earned the rank of Major. And so first of all, thank you for your service too.
Absolutely.
We appreciate that. Can you talk about the connection and your time in the military to where you are today?
Sure. Well, I took the health professions scholarship as a medical student, and that allowed me to have my medical school paid for with that program. And then I went on to do all my medical training after that through the Army. And so that included residency, which was out in El Paso, and then a fellowship that I did at Walter Reed in Maryland.
Wow.
And so I did a total of 9 years of active service.
Wow.
With that.
Well, we love that. So thank you again for your service. And let's just kind of jump into what it is. Let's start with explaining rheumatology.
Sure.
You might have heard that word. What does that mean, maybe to someone who's not really sure about that?
It's a great question. And the joke is that even sometimes in the medical world, not everyone knows what rheumatologists do. So it's a good question. But we treat arthritis and autoimmune diseases, would be the general description. Now, there are a lot of different things that we see and that we treat. Some of them are quite common. Things like rheumatoid arthritis would be one of the common things that we see and that we treat. Psoriatic arthritis, another common thing that we see. And then sometimes unusual things, vasculitis conditions, relapsing polychondritis. Some of these we only see a few cases in a million per population. And so, and there's a lot of things that are, that we might not see every day, but occasionally we will see one of these less common conditions.
So is that what drew you to this field, this specific, practice that you're doing now?
It is. I enjoyed seeing some of these unusual cases, some of these interesting conditions that might be less common.
Yeah.
So yes, absolutely.
Well, let's talk about some of that. You said there's 100 different diseases. That is just impressive enough. 100 different things it could be. I know
Sure.
A lot of us tend to maybe try to figure it out ourselves.
Sure.
Dr.
So, Google, right?
Right. We all unfortunately turn there, and that's a mistake. We've learned that. But whenever they're coming into your office, what's kind of the first step? If I was coming to see a rheumatologist, what
Sure.
kind of happens?
I really think that whatever treatment we're going to recommend, it starts with getting as accurate a diagnosis as we can. And usually that starts with getting a history from the patient, listening to what their issues are and what their history has been previously, and actually examining the areas that are bothering them. and so the physical exam. And beyond that, there are tests that we run. There are x-rays that we will recommend at times. But a lot of times the patient will tell us what's wrong if we just take the time to listen.
Well, I know we're going to get into some of those, and that includes lupus. I know there's a question about that we will definitely get to. Also, arthritis. I want to ask some questions, but let's start by talking about psoriasis and psoriatic arthritis. Now,
sure.
All of these, is it fair to say when you're talking about rheumatology that it all falls under a type of an autoimmune? Is that where this begins?
Most of our conditions are autoimmune. There are also some other conditions like, let's say, osteoarthritis that are not so much autoimmune, but they're arthritis that would be more from mechanical causes, just wear and tear arthritis. But many of them are autoimmune. That's true.
Meaning there's nothing that I've done to make it happen.
Correct. We don't totally understand why some people get them, others don't. We know they're more common in general in females, more so than males. We know that they tend to affect sometimes younger patients more frequently. But we don't totally understand why some patients will be affected by one of these diseases and others will not.
Well, let's start with psoriasis. If you can just tell us, exactly what that is, the inflammatory skin disease, and what it does to people.
Absolutely. Well, psoriasis is common enough that probably most of us know someone that is affected by it. And there can be mild cases, there can be some really more severe cases, and kind of everything in between. The most common form of psoriasis would be the plaque psoriasis that could affect, let's say, elbows, knee areas, and that would be probably the most common variety. There are a few other ones, and that would be things like guttate psoriasis or pustular psoriasis that could affect the palms and the soles. And so, but it is an inflammatory disease of the skin that tends to involve thickening of the skin. There can be flaking, there can be plaques, and unfortunately, it can cause a lot of discomfort, a lot of anxiety for patients that are afflicted with it.
Sure.
And so that's kind of some of the basic features of the psoriasis skin disease.
If you had to link that to eczema, is that in a different field? How do those two compare?
Sure. Well, they're both under the umbrella of skin diseases and dermatology. Eczema does not have an associated arthritis condition.
Okay. That's the difference between psoriasis and...
It's one of the differences.
Okay.
Yes, absolutely. And so we tend to do less with eczema and rheumatology because many of our treatments, when there is more severe psoriasis and maybe there's also psoriatic arthritis with that, many of the treatments that we would use for that would be for treatment of both the arthritis and also of the skin disease.
Okay. So let's talk about that. If someone has psoriasis and now you're talking, okay, you have the skin disease, you have the dry, the flakiness, kind of maybe similar to you're going to treat it how someone with eczema, you're kind of thinking it's just on the skin, but it actually could go a lot deeper than that. So what is the link to this arthritis, psoriatic arthritis?
So we think that probably between 10% and 30% of patients that have skin psoriasis will develop psoriatic arthritis.
Wow.
So not all of them, but a significant number of them.
Yeah.
And that could take the form of an arthritis that appears like rheumatoid, where it affects the small joints of the hands. In some cases, it could affect the spine, the hips, the pelvis, and some of those areas. There is a condition called dactylitis, where essentially it's inflammation of an entire digit, like a finger or a toe, that could become swollen and painful.
Yeah.
There are areas where you could have what's called enthesitis, inflammation, let's say, around the Achilles tendon where it attaches to the back of the foot, for example. So those are some examples of how psoriasis really psoriatic arthritis could be manifested.
What do people look out for then? Is this something, if you have a patient who has psoriasis, then what do they need to know?
Well, I don't want patients to worry about this.
Because it's not everyone. You said
it's not everyone.
Yeah, 10 to 30%.
I would say most patients, when they have inflammatory arthritis develop, they will know something is wrong, something is different.
Okay.
And so, you know, if you have psoriasis and you're not having any issues with your joints, I would say that's reassuring.
Okay.
And I, you know, hopefully you know that person will never develop the inflammatory joint manifestations. However, the features of inflammatory arthritis in general are things like swelling around joints, prolonged stiffness in the mornings particularly, symptoms that improve with movement activity and tend to worsen or stiffen up again with rest or with inactivity.
Okay.
So those are some of the general features. And then on examination, we're looking for swelling around joints. We're looking for tenderness around the affected joints. One of the things that we can see in psoriasis, but also in psoriatic arthritis, is changes of the nails, like pitting or splitting of the nails that can sometimes be a part of that.
Now, how does that compare to rheumatoid arthritis? You know, you hear a lot of people, and maybe their grandmother, their mother, you know, their family members have arthritis in the hands. And I mean, it can even affect, you know, where the fingers or you start seeing.
There can be deformities.
Yes. And so how does that compare to psoriatic arthritis?
Sure. Well, I would say the biggest clue is if we're looking at someone who has inflammatory arthritis and they have an established history of psoriasis skin disease, then my index of suspicion that they might have psoriatic arthritis is much higher.
Okay.
Whereas if they don't have any of the psoriasis changes, then I think rheumatoid arthritis would be more of a consideration initially.
Are they doing the same thing to our bodies, to everyone's bodies? Is it doing the same thing?
They can both cause damage to joints.
Okay.
Absolutely. How that actually affects the changes that you would see on an X-ray could be slightly different. For example, rheumatoid arthritis, we tend to see loss of bone density around the affected joints, what we call periarticular osteopenia. Whereas in psoriatic arthritis, there tends to be proliferation of bone. Sometimes there's actually excess bone that we can see on the radiographs. And so there are some differences, but they do both cause damage.
Wow. So what does this mean for people who are listening? Maybe they have, like I said, a family member, or maybe themselves, you know, they have arthritis. They're starting to notice that in their joints.
Sure.
There's no cure. So you hear that and you might feel a little defeated. But it's not all hope is lost, right?
There are good treatments. When we say there is not a cure, what we mean is that it's not like taking an antibiotic where you can have a 7-day course of treatment and then be done with it.
Yeah.
Most of these diseases are somewhat chronic, meaning that they need treatment over time.
And so you said over time, though, also, like with each generation, that medication, does it seem to be getting better and better?
Especially for psoriasis and psoriatic arthritis, there are some great treatments that even when I started my medical training were not available, even just in the last several years. And so these are medicines that we, in some cases, have seen patients who are just almost covered in psoriatic plaques and very uncomfortable, affecting their quality of life. And in some cases, some of those patients have had dramatic improvement with some of these newer agents.
That's good news.
And so that gives a lot of hope.
Yeah.
Because patients with psoriasis, in some cases, there's been research to show that they have an increased incidence of anxiety and some of these things that seem to go along with just the burden of dealing with their disease. And so, it's very, I think it's very hopeful that we have some of these treatments now.
Is this hereditary? That seems to be something we hear a lot of.
Sure.
My loved one had it, am I going to get it?
Yeah. So we don't know for sure that just because one of your family members had it that you are going to have that condition, but it's more likely. It's more of a possibility. And so most of these diseases, and psoriasis and psoriatic arthritis are this way. There is increased risk if you have a first-degree family member that has that condition as well.
So what do you do in that case? I know, like, for example, breast cancer, you know, we go and get testing done. Is there testing to be done? Is this something you just wait until a certain age, or you're experiencing a little?
Sure. You know, I think the suspicion and the concern would be higher if the family history is there, but it's not something that I would worry about
Yeah.
if you're not having any skin changes and if you're not having any issues with your joints. Most of these conditions, they do become clear when they're developing, and so we certainly, much of what we do is to take a look at these cases when there's concern that something might be developing. And sometimes when there's a new condition that's coming on, it may not be totally clear at first what is going on. Usually with time, it becomes more clear.
Yeah. What steps do you take to diagnose and treat, taking into consideration that everyone's unique? Everyone who
Sure.
walks in your door, you know, is a different story and has a different background. And so how do
Absolutely.
you go through that process of determining it's this or this?
Yeah, I think it goes back to the history and physical exam that we talked about. And so a lot of times there will be clues from the patient's story that will give us really some really good evidence of what might be developing. The examination can give us some important clues, looking at the joints, looking at the skin, and seeing the changes there. And then sometimes there's additional testing like x-rays, lab tests that can shed additional light. So all those things are important. And then as far as when it comes to deciding on treatments after a diagnosis has been made, it does, I think, partly depend on patients, on the individual patient. Sometimes there are occupational considerations about, you know, what that might lend itself better to a particular treatment for a certain patient. Some patients are, they have other medical conditions, what we call comorbidities, that would steer us toward certain treatments and away from other ones.
Yeah.
And so those are some of the things that we would consider when we're coming to a decision about how to treat an individual patient.
Are there lifestyle changes that we can make? So there's a lot of talk about medicine, and I know, you know, obviously we don't want to just rely on pain medication for anything that we're doing because we want to
Sure.
stay away from opioids. That's been a big story. So are there things that we can do? It's an inflammatory disease, a lot of these.
Sure.
Different things I can eat, different things we can do to help with that.
You know, this is a very important aspect of what we do. And we really do try to encourage patients. And this is whether they have an autoimmune disease, whether they just have degenerative arthritis. We really think that these lifestyle factors are important. What I mean by that is that it may not take away your diagnosis of psoriasis if you're doing all the lifestyle things, but it may make a big difference in how well it can be controlled with the treatments. And it may make a difference in terms of how well you feel. If you're following a good, healthy diet, if you're getting regular exercise, if you're managing stress and kind of dealing with the psychosocial aspect. And so we think all these things are very important. I have seen cases where a patient maybe was under increased stress from, let's say, a job or a home situation, and in some cases, that factor can cause their disease to flare up.
Yeah.
And so all these things are interrelated.
Isn't it incredible? It seems to always go back to that, our mental
is.
health. You know, we talk a lot about that and how important it is to take care of that because everything seems to affect, you know, everything else in our bodies. But
Absolutely.
we've just missed that for so long and how big of a role stress can play in our lives.
The
So,
mind-body connection.
Yeah.
Absolutely. Yeah.
an important connection indeed. We did have someone ask about lupus. So I would like to talk about that. That's
Absolutely.
something else that you would treat.
Yes.
I've heard of lupus. I know it kind of seems like a very scary diagnosis
It
if
can
you
be
hear
scary.
that. So can you tell us again what it is
Sure,
and what
sure.
that means for someone?
So we have to start by defining what we mean by systemic lupus. Because when we say lupus, it could mean one of a few different things.
Okay.
Lupus can be a skin disease. That's called cutaneous lupus or skin lupus. There can be a condition called drug-induced lupus, which is some of the features of lupus that seem to be caused by a medication. And then there is systemic lupus, which is kind of the condition I think that most people are thinking of when they say, I have lupus.
Okay.
And so Lupus is what we consider our prototype autoimmune disease. It has been studied for years and years. We still struggle with this disease at times, meaning it can be a challenging disease to treat and control. We have good treatments, and yet it still can be a challenging disease sometimes to control. The individual patient with systemic lupus can have a lot of different things, meaning that there is not just one flavor of systemic lupus.
Okay.
An individual patient could have, you could have one patient, they might be afflicted with the skin changes of lupus with a rash on their face and with, let's say, inflammatory swelling of their joints, inflammatory arthritis, and perhaps, some issues with sores or ulcers inside the mouth. And so that might be one person's experience with systemic lupus. Another person might have a very different experience. There could be let's say, an issue with having low platelets in the blood that are responsible for forming clots and stopping bleeding. There can be inflammation around organs, like inflammation around the lungs, what we call pleuritis or pleural effusion. And so my point is that there can be a lot of different ways that this disease can manifest in an individual patient. And it can be relatively mild, and it can also be severe and life-threatening, and everything kind of in between.
So I know the question was, how treatable is it? And it sounds like it's a case-by-case basis.
It is. It's very treatable. There's absolutely good treatments for systemic lupus. Is it a challenge sometimes? Yes. But there are absolutely good treatments for systemic lupus.
Well, I believe that is good news.
That is
so
good
I hope
news.
that answers your question.
Interestingly, one of the treatments that we recommend for almost everyone that has systemic lupus and also for skin lupus is a medicine called hydroxychloroquine, Plaquenil. And so that medication was developed to treat malaria back in the 1950s. But it now has an important job in treating lupus. And so that ends up being one of the medicines that is important for most of our patients that have systemic lupus.
And you heard a lot about that even with COVID, right? That was
We
brought up.
heard a lot about it.
We have heard that name, the medication that you were just bringing up. So that is something that's used to treat lupus, though.
It is used to treat lupus,
interesting.
absolutely. Yes.
Now, we did have another question. It was talking about rheumatoid arthritis and how it affects your organs. And
Sure.
how does it affect everything else going on inside you? Because it can, correct, if it's left untreated?
It can. And so rheumatoid arthritis, we think of it as a disease that primarily affects the joints, causing inflammation. But it's also true that especially in more severe cases of rheumatoid arthritis, and perhaps in cases that haven't been treated, that there can be other ways that it affects other organs.
Okay.
What do I mean by that? There can be an associated inflammatory disease of the eye. And so there are some rheumatoid-related inflammatory eye conditions. And so that can be a challenge that we would take on with an ophthalmologist, with an eye doctor.
Wow.
There can be lung manifestations with rheumatoid arthritis. And so occasionally there are patients that will have what we call rheumatoid nodules of the lungs. And in some cases there can even be inflammation around the linings of the lungs that could cause fluid to accumulate. And so those are some of the types of areas where we could see rheumatoid that affects other organs, other systems. Don't necessarily see it all the time, but those are certainly other things that we can see and that we should be looking for in patients that have these diseases.
Is that where staying on top of it, though, with the medication, I mean, does that help slow that down? Are you noticing that it helps slow the progression of arthritis down?
Certainly. And so for many of these specific manifestations, when the arthritis is well controlled, we do think that it helps to control some of these other things from happening as well. The other thing I would point out is that, we used to see a couple decades ago many more examples of rheumatoid arthritis patients that had, let's say, fingers that were deformed, hands that were permanently affected by the disease. And we still see that some, but it's not nearly as prevalent as what we used to see back before we had some of the treatments that we do now, and before we, I would say, treated it as aggressively as we tend to now.
Can any of that repair itself, or how does that work? If you have someone who come to you, you know, hey, I never went and got treatment,
Sure.
and I am now seeing that I'm not able to move. Is that treatable, or is that?
You know, sometimes it's hard to sort out how much of inflammatory arthritis is due to chronic damage and how much is due to active inflammation. And the first thing we want to do in that case is to try to control the active inflammation. Meaning if someone is coming in, let's say they've had long-standing rheumatoid that hasn't been treated, we want to try to get that under as good a control with treatment as we can. And it's a little hard to say. They may have some permanent changes, like erosions that we can see on x-rays.
Okay.
But their function may return really very well once the inflammation has been controlled effectively.
Okay.
There are other cases where there are permanent deformities that probably will never be completely corrected by medication. And in some cases, those have taken years or decades to develop.
Yeah.
And so we try to control it as well as possible, but we can't necessarily reverse, you know, an erosion in a joint that's been present for years.
This is something we were talking about in the newsroom. So this
Yes.
goes back to a question I've heard this so many times about popping your fingers, how that can cause arthritis. So we need you to set the record straight. Is that doing damage to our joints? Is that bad to do?
I would consider that to be a myth, an urban legend.
There you go.
So it is okay
You can pop
to
away,
pop
huh?
your knuckles.
Doctor says.
How about that? No conclusive evidence that I've seen that this is a cause for arthritis or that it's going to cause you problems later.
Where do you think that started? Have you heard
I
that?
have no idea.
Okay. Maybe somebody just wanted their child or somebody to quit doing that, huh?
Probably so.
Well, again, if you are joining us, we want you to ask those questions below. This is an interactive Facebook Live. I've learned so much today. We've just been talking about 30 minutes now, and Dr. Wagler, we appreciate you sharing all this because there's been some great information here. Also, if you have a family member or a loved one who maybe suffers with some of the things that he's talked about today, make sure you share this with them. Let them check this out. You know, you are a specialist, so if someone wants to come see you, how do they go about that? Do they need to talk to their family doctor first? What's the steps for that?
So generally, we like to get a referral from whoever the primary provider physician is. And that is for a couple of reasons. Some insurances require it, but whether or not that's the case, it's just helpful to keep the primary provider, the primary physician, in the loop, and also to see what's already been done in terms of testing, other labs, to see the medical history from the documentation.
It's going to give you a big advantage, huh?
Absolutely. Knowledge is power.
Absolutely. What about anything like you talked about comorbidities, which again, that's another thing that I feel like we learned with COVID. Different things, maybe diabetics. Does any of that affect, how does that play into arthritis and rheumatology?
Sure. Well, particularly with psoriasis, we have found that psoriasis is sometimes associated with some other medical conditions.
Okay.
And that would be things like the metabolic syndrome, where there's impaired fasting glucose, where there are lipid abnormalities, kind of this whole cluster of things that go along with what we've described as the metabolic syndrome, which is a risk factor for having some other problems. And so there is some association between some of those conditions and psoriasis. And so we ought to consider that, and we ought to be diligent in trying to address those other factors to help our patients be as healthy as possible.
So maybe that's not the cause necessarily, but there could be a link. Is that kind of what you're saying?
It's what we would describe as an association.
Okay.
You're right. But they essentially have found that there is an association with the metabolic syndrome and patients that have psoriasis. There seems to be some kind of a link there. Whether it's causative, I wouldn't say that necessarily, but it should cause us to think about these other risk factors
Sure.
when we see someone that has psoriasis.
And again, go back to making that patient whole altogether,
Absolutely.
right? So they feel better, they can do life better, and
Promoting health and
Yeah.
not just treating the disease.
when, again, I want to ask this question. I know you hit on it a little bit about changing your lifestyle, changing your diet and exercise, but are there any specifics when you're talking about inflammatory, anti-inflammatory foods that we eat?
Sure.
You seem to hear a lot about that, but what are some specific things that maybe we don't think about that could be making that worse?
Sure. So
And better. We
I
want to do the good
hesitate.
too.
Sure. I hesitate to make a blanket recommendation.
Okay.
Because sometimes one size does not fit all.
True.
In general, if I could somehow just change what everyone does in Texoma in terms of like how would we change the diet as a whole?
Sure.
What kinds of things would we do? Well, we probably would eat less processed food. We probably would eat less fast food. And we probably would eat more things like healthy fats, healthy forms of fat like avocados, unprocessed oils like olive oil.
Okay.
These things, there may be some anti-inflammatory effect from those things.
Okay.
And we also just anecdotally have seen some benefit in terms of how patients feel, how they function, sometimes with some of their joint symptoms, when they decrease or when they modify carbohydrates. So sometimes carbohydrates, of course, they taste great, right?
Yes, they do.
But sometimes they also cause some problems.
Sure.
And so particularly for certain patients, we find that the carbohydrates seem to be a key that kind of unlocks a better function once they get that under better control.
So all those extra rolls that we're eating with the butter, not a good idea maybe, huh? It's just limited. That's the key we all need to take away anyways, huh?
Moderation in all
Moderation is key. We do have another question, so we want to
Yeah.
get to that as well. Kim's going to fill us in.
This person wants to know if rheumatoid arthritis affects the liver.
Does it affect the liver, rheumatoid arthritis?
Sure. So can rheumatoid arthritis affect the liver? The answer would be not typically. I won't say never, because most things in medicine are not 100% yes or no, but not typically. The reason that we have to monitor the liver with most of our patients that are on rheumatoid medicines is mostly to make sure that the medicines are not causing an issue with the liver. And so we do monitor liver numbers pretty regularly for most of our patients that have rheumatoid arthritis. But it's not usually because of the arthritis, it's more because of the medicines.
Good question. Are there any others we're skipping over? Okay. Just want to make sure that we are not leaving anything out. What is probably the number one question, would you say, you're asked? I know, again, you see lots of different patients that
Sure.
walk in your office, but is there, if you had to think of one or two that most people ask you, what would those be?
You know, a lot of people suffer from chronic pain. And I think probably the most challenging case is when it's not just in a certain joint or a
Yeah.
certain area, but maybe it's all over.
Yeah.
I hurt from head to toe, all over pain, and it's been present for a long time. That's a hard scenario.
Yeah.
That's a hard scenario because there's not always, just one certain medical treatment that's going to resolve that pain. And so that's something that comes up at times. We emphasize, getting back to the lifestyle, trying to address lifestyle factors that can be part of the answer to some of those chronic pain complaints. So that would be one thing that comes up. I think also a lot of people have questions about diet and nutrition, just like what you were asking about. If I eat the right diet, does that mean that I won't have this condition? If I eat the right diet, do I still need medicine? And I would say the answer to that depends. I've seen cases where people had significant improvements where they could come off certain treatments, or maybe they needed less frequent treatment or less intense treatment. In other cases where it allowed their disease to be better controlled, maybe they still needed medicine, but the effects were that much better once their lifestyle factors were better optimized.
Yeah. No, those are great points, great takeaways. I just really appreciate you being here today and sharing, again, all about what it is that you do and how you've been serving the community whenever it comes to rheumatology. So again, Dr. Wagler, if you'd like to go see him and maybe get in contact with him, he recommends going through your doctor, but all you got to do is talk to them about that, and they'll send a referral over at United Regional Physicians Group. Before we go, if there's anything else you want to share with Texoma, I want to give you that chance, but I think you've done an excellent job answering our questions and really getting us up to speed on this.
No, actually, I just appreciate the chance to talk about this tonight. These are things that I enjoy, that I think are very interesting, and I am excited about some of the things that we can do that we weren't able to do even just a couple of years, a couple decades ago. And I really appreciate the community here. It has been a privilege to be here for the last almost 5 years now, and I'm looking forward to being here for a lot longer.
Well, we're excited you're part of Texoma. And speaking of Texoma, we can't go because there is one more question. Kim,
another question.
What is that?
What are the main changes a person with fibromyalgia could make to improve pain management?
Fibromyalgia, and if you can maybe just explain a little bit about that, but
Sure.
that is something else you treat. We said there were 100 of them, so there's a lot. We've just hit on a few.
Sure. So that kind of gets back to when I mentioned a moment ago that some people, they hurt all over.
Yeah.
They describe pain in their muscles, pain that's maybe all the time. Maybe it's triggered by certain things, but it never completely goes away. Oftentimes, they will have poor quality sleep. They will have what I would describe as non-restorative sleep, waking up and still feeling tired and achy and like you didn't really rest. And so this is a very common issue. Now, whether it is a rheumatology condition or not is another question, because we don't necessarily have, quote, the answer for all that chronic pain in rheumatology. We do see a lot of people that struggle with it, and we do try to help them. And sometimes we see it in patients that have other conditions like rheumatoid arthritis. And so we're kind of addressing both things with their symptoms. I would say I don't think we have a simple answer that resolves that chronic widespread pain. However, there is exciting new research that is trying to get a better handle on what is involved in actually changing perception of pain, improving patients' function, improving their quality of life when they deal with chronic pain. I don't have a simple formula, but I will say that there are resources that we're collecting that to try to help patients with that in terms of certain books that we have found helpful. There is what I will describe as the supportive care clinic at United Regional Physicians Group. That's an effort that's been started in the last year, and that really is focused on helping people that have chronic pain, not prescribing medicines necessarily, and not doing procedures, but doing the kind of the other part of helping patients address this chronic widespread pain.
Wow, I love
so those
that.
are some of the things that we do to try to address that.
I think hope, there's a lot of hope, it sounds
Absolutely.
like. And I think that's what people need. If they're hurting,
Absolutely.
they're in pain, you want to have an answer, at least some hope that there could be some
I
solution.
think that's a very important thing, because if you're suffering with pain, I think a lot of times it might seem like there is not hope.
Yeah.
And I would say there is absolutely, there are some very helpful things that can be done to address those issues.
Well, that is really good news. It's good news for Texoma. And again, Dr. Wagler sharing today all about how he helps treat Texoma. Make sure you share this and save this. If you have any questions, you can give their office a call, and we will have that number in the comments for you as well, I believe. Kim, is that correct? So you can just give their office a call as well if you have any questions, and they can help direct you back to your doctor so you can get that referral and go see Dr. Wagler if you need to. Thanks again. We appreciate you being here, and glad you're here in Texoma.
Thank you so much, Ashley.
And thank you, Texoma, for joining us. We hope you enjoyed the rest of your evening. We'll see you next time.